ago, I was in New York, so it's always nice to come back for any occasion, and this is a wonderful event that Dr. Sechkin is hosting here today. So I am pleased to be a part. So today I'm going to speak about endometriomas and fertility. Before we can get too much into fertility, we have to actually talk about what an endometrioma is. So an endometrioma is an endometriosis cyst of the ovary, also known as the chocolate cyst. These occur in 20 to 40% of patients with endometriosis. It's called a chocolate cyst because when they rupture, the fluid within is old blood. It can be thin, it can be thick, but it looks like chocolate. We often see them bilaterally on the right and the left. And then the picture on the lower right here, when they occur bilaterally, we refer to those as kissing ovaries. They tend to scar to the back wall of the uterus, and they meet in the center. Endometriomas, unless they're incredibly small and only on one side, typically are pretty advanced endometriosis, stage 3 or 4 endometriosis. As Dr. Shin referred to earlier, we have a scoring system for endometriosis, which refers to the extent of disease. What is important to recognize is that the symptoms do not always correlate to the extent or severity of disease. So it's not uncommon that, I'm in the OR doing surgery for fibroids, and surprise, someone has stage 4 endometriosis. So it's always, I find, amazing, but the symptoms do not correlate to the extent of disease. The symptoms of endometriomas are similar to the regular old symptoms of endometriosis: pain with periods, pain outside of periods, pain with sex, infertility, and no symptoms. So if you've been given a diagnosis of endometriomas, does that mean you're never going to have children? No. Endometriosis does not equal infertility. Endometriosis is certainly associated with subfertility, but it does not mean infertility. 30 to 50% of patients with endometriosis will have difficulty getting pregnant. So what are the causes of subfertility in a population with endometriosis? We don't totally know. We think we have some ideas, but it's still a little bit of a mystery as to why the two are associated. In general, we know, endometriosis occurs in about 10% of reproductive age women, in 30% of infertility population. So we definitely see it more commonly in an infertility population. So we're going to talk about these three causes. So one of the causes that we think is related to infertility is that endometriosis essentially can produce a toxic environment. So these implants in the pelvis or implants on the ovaries, they are active when your ovaries are working and you're having cycles. These implants are producing estrogen and aromatase and cytokines and interleukins and all sorts of inflammatory substances that we think those inflammatory substances can impact the embryo, the ability of an embryo to implant, the receptivity of the endometrium, and especially with endometriomas themselves. An endometrioma is, again, the cyst within the ovary. If you have that sitting in the ovary itself, then that can have a negative impact upon the ovarian cortex. I actually think this is Dr. Sechkin's picture. I just Googled it, but so endometriosis can cause. This one makes a lot of sense to a lot of people, but can cause infertility because of distorted anatomy. Well, in order to appreciate distorted anatomy, this is distorted anatomy, I assure you. You have to know what normal anatomy looks like. So a normal uterus, that uterus actually has a fibroid, but a normal uterus looks like the picture on the left. It moves around. You can clearly see the ovaries. You can see the fallopian tubes draped over top. In pregnancy, an egg is released from the ovary. It travels down the fallopian tube, makes its way into the uterine cavity. So if you have a pelvis that looks like this, it makes sense that when the fallopian tube is not even identifiable and not near the ovary any longer and everything is stuck in cement, it makes sense that a egg would have difficulty traveling along the course of the fallopian tube. So another hot topic these days is endometriosis and its impact on ovarian reserve. Ovarian reserve, we're going to talk a little bit more about that, and it gets a little bit technical, but you're going to hear that a lot if you see an infertility doctor, if you see a doctor who specializes in endometriosis, especially when we're talking about endometriomas. But ovarian reserve essentially refers to your ability to produce quality eggs. So you have your maximum number of eggs before you're even born. Midway through your mother's pregnancy, you had about 6 to 7 million eggs. Once you're born, that drops to about a million, then about puberty, 300, 500,000. Once you hit menopause, 1,000. So fertility starts to really decline mid-30s as a consequence of diminishing ovarian reserve. So there's lots of tests that we use to measure ovarian reserve, sort of the alphabet soup of testing, and a lot of times we throw out these terms, FSH, AMH, AFC. So what are they? And I think it's important for you to recognize what they are because we do use them a lot, especially when we're talking about ovarian reserve. So FSH is follicle stimulating hormone. It is made by the brain. It is, or made in the brain. It's a blood test that is performed, and it's sort of an indirect measure of egg quantity. So when you're young, your brain sends out the FSH telling your ovaries to ovulate. You're young, your ovaries are working great, and so very easily, very quickly, woman ovulates. As you get older and your ovaries aren't working as well anymore, your brain really has to keep sending out that FSH, ovulate, ovulate, ovulate. The pathology behind it is a little bit more complicated, but that's essentially the gist. So your FSH increases with decreasing ovarian reserve. Anti-Müllerian hormone, the name anti-Müllerian hormone is actually named for what the hormone does in a male fetus during development. It has nothing to do with female ovaries, so it doesn't. It doesn't. The name doesn't really ring. Doesn't make sense. Anyway, anti-Müllerian hormone. Okay, so this also is an indirect measure of egg quantity. It is made by the little small follicles that are in your ovaries. So when you are young and you have lots of great follicles in your ovaries, eggs, then your anti-Müllerian hormone is high. As you age and your follicles decline, then your AMH naturally goes down. Your antral follicle count is the only one that's not a blood test. It's actually an ultrasound. And literally all it is you're doing an ultrasound and you're counting how many eggs are in the ovary. So on the left, that is a beautiful ovary with lots of nice eggs, and on the left is what my ovary looks like with not a lot of eggs. The other thing that is a little bit is helpful, the FSH and antral follicle count have to be timed. So they're usually around day 2, FSH day 2, day 3. The antral follicle count should also be in the early phase of your menstrual cycle. Anti-Müllerian hormone can be at any point. FSH also cannot be measured if you're on birth control pills because that is not really a true measure of what you are doing on your own. So these are helpful, and we like to use them as physicians. Especially, we like to be able to say, okay, what this number means is XYZ. But the problem is that these numbers are predictive of how well you might respond to hormonal stimulation. So if you have IVF, if you need to have medicines to help you have a baby, these are helpful, and they tell us how well you respond, how many eggs you may make. But these are not predictive of your ability to conceive or of egg quality. So the problem with endometriomas and ovarian reserve, by looking at women who have endometriomas and comparing them to women who do not have endometriomas, we have found that in women who have endometriomas, there are fewer eggs in the surrounding ovarian tissue around the endometrioma. It appears that the eggs don't mature as well. And there also is a lower antral follicle count and AMH hormone. So that's terrible. We should get rid of them. Not so much, because surgical treatment of endometriomas can also reduce ovarian reserve. So it can worsen what's already not so great to begin with. And this is further increased when you have cysts of both ovaries, so if they're bilateral. Also is true anytime you're doing surgery, especially for endometriomas, they're very sticky. It can be difficult to separate the cyst wall itself from the ovary. There is a small risk of ovarian failure or menopause if in the setting of bilateral endometriomas. So this is great, but what we really care about, as from a patient perspective, is you don't care about your antral follicle count and your AMH. What you really want to know is, well, can I have a baby? And similar to FSH, AMH, antral follicle count, those are numbers. We know that there's a response of ovaries to having an endometrioma and to having removal of an endometrioma, but again, it doesn't always correlate to your ability to have a baby. Now, obviously, if your AMH is like not measurable and your FSH is in the menopausal range, then that's a different situation. But when it's sort of, it's always in the gray zone, just to make life complicated, but it doesn't necessarily mean that you won't be able to have a child. And in women with endometriomas and infertility, we actually know that in an infertile population, in a symptomatic endometrioma, surgery can improve your chance of spontaneous conception. When you're talking about IVF, actually what we see is that you can have similar reproductive outcomes. So even though I just said that endometriomas have a negative impact and removing the endometrioma can have a negative impact, and it can decrease your AMH, when we look at IVF outcomes, they appear to be the same whether or not you remove the endometrioma or not. And we think that that reduced ovarian reserve might be due to the endometrioma itself rather than surgery. And so you have to think very carefully about when to intervene, whether or not you should intervene, and it really is based on several factors. Symptoms, you know, if you have huge endometriomas and are in debilitating pain, we have to do something. I mean, you can't get pregnant and go through an IVF cycle if you can't walk. The size also. There's definitely consensus we really leave small endometriomas alone, but when someone has 12-centimeter bilateral endometriomas, there's other things that we have to factor in when we're talking about pregnancy, like your ability to even, if you stimulate the ovary, are you going to get much? Are you going to be able to reach the follicles that are there? Is there a risk of contaminating if you go get those eggs with the endometrioma fluid? You can potentially seed that endometrioma and have then an infected endometrioma, which is a mess. So there's a lot of things that have to be taken into consideration. Also, the larger and the more complex these endometriomas become, we also have to start worrying about potential for malignancy. While that risk is low, it does exist. And so there are situations where you do have to intervene. So management of endometriomas is very controversial. There are no clear guidelines, and there really has to be a very thoughtful and thorough conversation between patient and the physicians, which often includes the infertility doctor as well as the surgeon who might be doing the surgery, if not the infertility doctor, which often is not the case. And that's it. Thank you. I think we have questions at the end.